I wanted to give you guys a little bit more information about my journey and how I got here, though that was a really nice conclusion because I am here in Portland now and loving being here. But I think what you need to know is I love taking care of kids with rheumatic diseases, especially lupus. And when you get to work with really nice people, great families, and forge a relationship, which you get to when someone has a chronic rheumatic condition like lupus, it's very fulfilling. So my journey, as you heard, I did my training in Indianapolis, and my first job afterwards was in Minneapolis, Minnesota. And after 5 years, I made the move to Kansas City, Missouri, where I joined another pediatric rheumatologist who unfortunately a couple years later left, leaving me alone to practice. But given some time and really great support from the hospital there, I was able to build a pediatric rheumatology section of exactly 5 pediatric rheumatologists. That is a really strong section, a really great hospital, and it's a really great place where they take care of kids with rheumatic conditions. Then I was able to move out to Randall Children's Hospital, which is part of the Legacy Health Group, and work with a couple of really great pediatric rheumatologists who are really talented. And we have a really excellent group of people, nurses, front office, who help take care of kids with lupus. This was one of the patients I took care of up in Minneapolis, and she obviously presented with a rash, not necessarily classic, but certainly indicative of lupus. She also had renal disease. I wanted to talk about the idea that kids do get lupus, because they do. In 10 to 20-year-olds, the incidence is about 1 in 20,000 in Caucasians, 1 in 8,000 in Hispanics, and 1 in 5,000 in African Americans. And it absolutely happens, and we see it regularly. In general, for those kids less than 15, it's about 1 in 20,000, and the reason for that is there's a greater incidence of lupus after puberty than before, though it happens in both school-age kids and adolescents. Females more than males, as most people know who have any introduction with respects to lupus, and as we talked about before, more in African Americans than Caucasians, in about 5,000 to 10,000 kids with lupus in the US. Another patient of mine, this was during fellowship, who is Native American, who presented with malar rash, who also had significant renal disease. So what's different about lupus in children compared to adults? I'm going to touch upon a couple of different aspects. One is that in general, kids' disease severity is more than in adults. And that's not individually. There are many adults with very severe lupus, but overall, children just have a higher percentage of renal and central nervous system involvement. And one has to just be aware that you really want to make sure you know everything that's going on as much as possible about the disease activity, and making sure you're doing everything as quickly as possible to get it controlled. This is a very vulnerable time for people in general, adolescents, with respect to their identity. And it's hard enough to find one's own identity in general, more or less how to have a chronic illness along with the rest of whatever it is to mature. And finally, the relationship triad, the relationship between physician, patient, and, yes, parents. And you cannot leave that last part out while successfully taking care of somebody who has lupus. I have a couple of examples of patients that I've taken care of here in the Portland area over the last couple of years. The first, a 5-year-old Hispanic girl from Southern Oregon who came with a history of low platelets. And during the evaluation for wondering if she had lupus, she unfortunately had a pulmonary hemorrhage in which she was very sick and in the intensive care unit for a number of weeks and over 2 weeks on a ventilator. This is something that is not the norm, but it absolutely happens, and it's the reasons why not only is it important to diagnose lupus, as you guys know, but to try to do it as quickly as possible. When it's diagnosed, you can start treatment and hopefully prevent some of these complications. The second patient was a 14-year-old who presented with leg pain and swelling, who ended up having a clot in her leg, and on further evaluation had clots in her lungs as well. A lot of chest pain, multiple hospitalizations to try to get the pain under control, to get the clots lessened, and it turned out that she also had involvement of one of her heart valves. Her lupus is well controlled. She also has antiphospholipid antibody syndrome contributing to causing those clots, and is going to need surgery to be able to repair her heart valve. This was another patient of mine who presented in the hospital with a lot of edema, who had WHO class 5 renal disease, and of course a malar rash. Adolescence, a time of vulnerability of identity. So imagine, some of you don't even have to imagine, but think about the idea of teenagers, junior high school. What does it mean to fit in with the other kids? Trying to find peer groups, trying to know who one is and how to make that work. And while doing so, being told you have a chronic illness like lupus. Then, after the diagnosis and trying to understand what that all means, how is one's physical features going to be impacted by going on high-dose steroids and gaining weight, which can be considerable, getting not only facial acne, but acne all over one's body. And I think we all know in those times, without a chronic illness, without being on a lot of different medications, what it is to just get one pimple, more or less having acne all over one's face. And it is something that it's difficult to, on the one hand, be objective as a treating physician to try to help make best decisions, but to also empathize, not only with the child, but their parent, who's trying to make decisions about what to do for the child's best health, about a condition they know nothing about, listening to some person they don't know, and giving medications that causes these problems with their child. It's not easy. And of course, during all of this time, hitting middle adolescence, when rebellion is the norm, when children are trying to gain independence and not doing that with things that are acceptable, but not doing that with things like going to doctor's appointments or taking medications is quite a tricky balance. This is a patient of mine from quite a long time ago, and she is a really neat young girl who, with her diagnosis, needed treatment. She really well put together, and her mom was salt of the earth, and they had a great relationship, and the three of us had a really good relationship. But imagine, I want to give you a visual with respects to the impact of going from this to this. What does that do? This is after a long course of steroids. Let me be clear, I do not like steroids with respects to what they do in terms of adverse effects. The unfortunate thing is it is a very good immunosuppressant to help control lupus, and the goal, not only present but future goal, is how do we use less of this to get the same effect with respect to control of disease. But imagine for this patient who she was prior to and who she is now, and what happens over time in terms of her as she's forging an identity. Her cushingoid features went away. She survived with respects to the change or the altering image, if you will, but will I really ever know, or will we really ever know how that time impacted who she identified herself to be? I think probably don't really understand the impact. So, denial. Really can't talk about the treatment of adolescents, or adults for that matter, when talking about denial. So common sense and the idea that, don't you understand if you don't take your medicines, what will happen? You know that you hurt if you're not doing the things that you know help you. Why would you not do that? Any parent, when you hear them asking their child that question, you sit there and it makes no sense, right? But what we know is that denial is one of the most powerful ways of coping. And adolescent children do a really good job of being in denial. And so I have a story to share about both parents and patients with the idea of the power of denial. I'm in my office in the clinic room with a patient and both of their parents. And I'm scratching my head asking, I don't understand why we're not getting the clinical effect we think we should be with the treatment we've prescribed. And is there, what's going on? Is there any possibility Johnny is not taking his meds? And both parents are like, no, that is not possible. We hand it to him, we see him take it, it's just not possible. And I'm like, okay. So when I examine my patients, I have them take their shoes and socks off, and he takes off his shoes and out drops one of his pills from his shoe. And you couldn't believe the parents' jaws dropping with the idea that for some way their child, who they know is doing the things they're supposed to do, was not. And it was just a great example of what denial or what the power of the mind can do, even though it makes no sense with respect to the goal of treatment. So I really like that as an example. Never be too sure. That relationship triad. You have the patient, the parent, and the physician. And I think in the adult world, though, patients bring family members in, the responsibility of the physician is to the patient. That's it. That is what one needs to have and has. In pediatrics, it is threefold. You have a relationship with the patient and the parent. Without a good relationship physician-parent, you're not going to get buy-in from the child for the most part. Particularly if they're school age, you need a stronger relationship with the parent because the parents basically are the ones who are dictating the care. As the child gets older, it helps to have a stronger and stronger relationship with the patient because you as the physician can have influence if they respect you, if they know you care about them. There is power in that. There's also power in supporting the parents in their frustrations in dealing with their adolescent child. Understanding that things are not always easy, that negotiations are happening 24/7, that those sorts of things really help when it comes to the idea of having the family feeling supported, not only by the physician, but the clinic, knowing that you're there to help, not only when disease flares, illness occurs, but also when socially things are going awry. Another patient of mine, one with more mild disease who presented with a classic butterfly rash, but also had low white counts as the presentation of her lupus. Again, you can get cytopenias, low white counts, hemoglobin, platelet counts associated with your lupus. She did not have renal involvement, central nervous system involvement, and again, treatment amount of steroids that one would use would be less, and other immunosuppressants may not be the same as in more severe disease. I just wanted to point out that every pediatric lupus patient does not have a level of severity like some of the other ones I presented. And it's such a cute smile, right? So why might it be a good idea for a pediatric rheumatologist to take care of a kid with lupus? I think it really helps spending 3 years doing a pediatric residency because all you do is take care of kids 24/7. You learn about the development of them. You learn about the ways of being of adolescence. You learn about how one's going to develop one's skills in developing relationships with parents. I think that those are really important, and that when kids with rheumatic diseases are not taken care of by the pediatric world, they don't necessarily gain the benefits of some of that experience. We work in places where our staff are used to taking care of kids. So the idea of making them feel comfortable, having it be a safe place for them, knowing that you're going to get calls from parents, not necessarily that are clinically based, but emotionally sometimes they need that support. And if you're lucky like I am, you get to work with people who are really good, really talented with respects to helping and having people feel good about the care that they get. And that familiarity with severity of disease, making sure one is on the aggressive side of getting the lupus controlled, trying to prevent the flares, trying to anticipate further evaluation of other areas, even though there might not be clinical symptoms. Maybe we're going to get an EKG and echo to make sure the heart is okay. Getting baseline studies, because 2 years down the road, there may be a problem. And if you don't do one initially, you're not going to know if it was there previously or not. So some of those things I think are informative to hopefully the good care that these kids get. So why not a pediatric rheumatologist? I mean, why would other people take care of kids with rheumatic diseases like lupus? And availability and access is really the issue. There are approximately 250 pediatric rheumatologists in North America and another 250 around the rest of the world, which is a lot better than the 100 who were in North America when I started my practice back in the mid-90s. So there are more, but there still aren't enough. And they're still not everywhere they need to be. There are states, Idaho, Wyoming, Montana, North and South Dakota, no pediatric rheumatologists, period. They don't have anybody. Oklahoma City, the state of Oklahoma, has one for the entire state. I feel really lucky that Dr. Kingsbury, Cartwright, and myself are the three that cover Oregon. We're the only three. If you want to get in, sometimes it's a very long wait. Sometimes it's a really long drive. Right? When I was in Minnesota, I had a patient driving from Wyoming to Minneapolis, Minnesota for me to take care of them. We have patients traveling from Idaho and Wyoming to Portland to help take care of them. We have patients from the Tri-Cities in Washington or from the other side of the state in Oregon to come see us. And that 3-4 hour drive is a burden. You throw a couple of younger kids in there with the patient, everyone's a little bit on edge, just to say. So it's not ideal. It's not ideal. So that the idea of what we can do in terms of having more pediatric rheumatologists available, there are universities that don't have a pediatric rheumatologist. Right at this moment, OHSU does not have a pediatric rheumatologist over at Dornbecker. So it's something where we hope to help get more and more to really help provide care in the way that I think patients with lupus should be taken care of if they're kids. So, my take-home points. Kids get lupus and tend to be more severe overall than adults. It just you don't have the cutaneous lupus that the adults have in terms of percentage, and it's something in which you just need to be aware of that. Diagnosis and treatment of lupus during adolescence has its own, and I'll say unique, challenges. And that the care of this patient population can best be served by pediatric rheumatologists if they're available. That's what I have for you guys.